Hi everyone, welcome to part 2 of Unit 6. In this lesson we'll focus upon fluid, electrolyte, and acid-base imbalances. We'll start off by examining and discussing the fluid imbalances, specifically hypo and hypovolemia, which we'll see is related to sodium balance as well. And then we'll move on to the electrolyte imbalances, hypo and hypokalemia, hypo and hypocalcemia, and then close off with the acid-base imbalances, specifically focusing upon respiratory acidosis, metabolic acidosis, respiratory alkalosis, and metabolic alkalosis. Please remember to read through this particular slide deck, as well as look at all the other learning resources that are posted on the Blackboard shell. In terms of sodium homeostasis, if you remember from A and P, the ECF volume is directly determined by the total sodium content in the body rather than the actual sodium concentration. We'll examine this in more detail. In other words, sodium deficiency or a decrease in total sodium content in the body leads to ECF or extracellular volume contraction, and similarly, an excess of sodium in the body leads to ECF volume expansion. And remember, ECF stands for extracellular fluid, as opposed to ICF, which is intracellular fluid. ECF is composed of plasma as well as interstitial fluid, and we typically talk about in terms of hypo and hypovolemia about ECF volume because that's relatively easier to measure, because you can measure plasma volume. You will see what it's related to in terms of blood pressure and the like. It's really difficult to measure volume within cells, or ICF. So hypo and hypovolemia is really related to ECF volume. So ECF volume contraction is hypovolemia and ECF volume expansion is hypervolemia. So if you look at this particular diagram, you will see that previously in E&P, when we were discussing the functioning of the kidneys, we know that the kidneys can excrete out various substances, various electrolytes, including sodium. So you would imagine if you take in excess sodium, well, maybe you should just excrete that out. And indeed, that is true. So if you look at dietary sodium changes, here you have a constant amount of sodium chloride, table salt intake, and that is kind of matched by the output as well. So there's a little bit, the output is a little bit lower because you do have some losses, so you can excrete out all the sodium you ingest or intake because you have to replenish some of the losses, right? However, if you increase it suddenly, you can see the sodium intake is increased here for this period of time, then yes, over a period of time, the output or the excretion of sodium will increase as well, right? But that takes some time to adjust to. It doesn't occur instantaneously. And over a period of time, you will see that you're still not excreting out all the excess sodium. And consequently, there is a sodium buildup within the body. And how's that manifested? It's manifested by the increase in ECF volume or ECF volume expansion. And how do we measure ECF volume expansion? Well, the easiest thing is to measure total body weight. Because when you have ECF volume expansion, say that it has expanded by 1 liter, that's essentially 1 liter of water, which is equivalent to gaining 1 kilogram in weight, right? 1 kilogram of water is equal to 1 liter of water. And there's no way to get around that. So in this particular diagram, what it's trying to explain is that as sodium content in the body increases, the water content in the body increases as well. And that's shown here by the increase in the body weight over here. If you decrease the sodium intake, then over time the output will also decrease, and then over time the volume, ECF volume contraction will occur. The total amount of water in the body will decrease. Why? Because the total amount of sodium in the body has decreased, and then it should go back to normal. So let's look at hypovolemia. So remember that hypovolemia results from ECF volume contraction. And why is that the case? Because there's a reduction in the total amount of sodium in the body. What are the etiologies of hypovolemia? 2 causes, renal causes and non-renal causes. Let's look at the renal causes first. In terms of renal causes, they can be absolute volume contraction. So there's a difference between absolute volume contraction, whereby you lose the actual amount of water from the body, water actually exits the body, as opposed to relative volume contraction, where the total amount of water in the body doesn't change, but the distribution of water between the three so-called containers, or the three buckets, have changed. What are the three containers? There's the ICF, or intracellular volume. There's the ECF, or extracellular volume, which is subdivided into interstitial spaces, and plasma. So when we say relative volume contraction, what we are really talking about is that the distribution between the three compartments, ICF, interstitial fluid, and plasma, has been altered. And specifically, volume contraction over here refers to plasma volume. So if the amount of water or volume in the plasma has been redistributed to the other two containers, to either to the interstitial fluid or ultimately to the ICF, then we say that there is a relative volume contraction, right? So in other words, volume has been pushed from plasma to the interstitial fluid and or the ICF. Total volume hasn't changed, but plasma volume has changed. That's what we mean by relative volume contraction, because it's really the plasma volume that we're most concerned with. So in terms of absolute volume contraction, you can have a diuretic or use, or excessive diuretic use, or prolonged diuretic use that can lead to increased excretion of water and leading to absolute volume contraction. Hypoaldosteronism can also lead to absolute volume contraction. If you remember, aldosterone is involved with increasing sodium reabsorption in the distal convoluted tubule, and when you absorb or reabsorb more sodium, you reabsorb more water. So if you have a lack of aldosterone, you're going to have a decreased reabsorption of water, leading to an absolute volume contraction. And various other renal tubular diseases can also, which we're not going to focus upon, lead to absolute volume contraction, like ATN, or acute tubular necrosis. In terms of relative volume contraction, nephrotic syndrome, which we saw in part 1, can lead to that particular condition, right? How so? Because the lack of protein in blood leads to increased fluid exudation from the blood vessels, specifically the capillaries, leading to a shift of volume from the plasma to the interstitial fluid, and ultimately we'll see to the ICF as well. So that's relative volume contraction. Those are the renal causes. What about the non-renal causes? Non-renal causes will be a little bit easier to understand. If you have bleeding, yes, you're going to have absolute volume contraction. Similarly, with the GI fluid losses, severe diarrhea, severe vomiting, secretions from an ileostomy or colostomy, that can lead to absolute volume contraction. In addition, fluid losses from the skin, as in severe burns or excessive sweating. It might be sweating, for example, if you're running a marathon, that is not excessive, that's to cool down the body, but if it's not replenished, that's going to lead to absolute volume contraction. What about relative volume contraction? Third spacing. In the case of severe burns, you have increased capillary permeability, if you remember from your previous pathophysiology courses in your PN program. That can lead to a shift of fluid from the blood vessels, from plasma, to the interstitial fluid. And that's the third space, that's why it's called third spacing. In the case of severe sepsis as well, you can get third spacing because of all the various inflammatory mediators, we've covered this as well, that are released. They all increase capillary permeability, leading to increased fluid exudation, a reduced blood volume, in other words. Hypervolemia, on the other hand, results from ECF volume expansion, and that is the total increase in sodium content in the body. The etiologies are primary or secondary. Primary is mainly due to oliguric renal failure and chronic kidney disease. Another cause could be hyperaldosteronism. As we recall, aldosterone increases sodium reabsorption in the DCT and thereby increases water reabsorption as well. Secondary causes of hypervolemia include heart failure and liver cirrhosis. We've discussed that previously. For example, in right-sided heart failure, you have an increase in venous congestion that leads to increased hydrostatic pressure and fluid exudation from the blood vessels. Similarly, in liver cirrhosis, it's mainly due to a decrease in the osmotic potential of blood. Let's look at the clinical manifestations of hypo versus hypervolemia. In terms of the jugular venous pressure, you can see in hypovolemia it's going to be decreased, in hypervolemia it's going to be increased. In terms of blood pressure, this is where it gets a little complicated. You would anticipate that for a hypovolemic client, the blood pressure would be decreased. Well, that's true if it's severe hypovolemia, but in the case of mild or moderate hypovolemia, because of the compensatory mechanisms that are present in terms of defending blood pressure, it's not as simple. What is measurable is an orthostatic drop. So that is far more pronounced in a hypovolemic client compared to a client that does not have hypovolemia. For a hypovolemic client, blood pressure, for similar reasons, would be anticipated to be increased, but sometimes it's normal, right? So normal to increase. In terms of the auscultation of heart sounds, for a hypovolemic client, you would anticipate that one of the compensatory mechanisms would be tachycardia, or increase in the heart rate, to increase blood pressure ultimately. And in a hypovolemic client, you have adventitious heart sounds such as the S3 heart sounds. For the auscultation of the lungs, normal. Typically for a hypovolemic client, in a hypovolemic client, you could have fluid buildup in the lungs as well, so you have inspiratory crackles. In terms of skin turgor, for a hypovolemic client, it should be decreased. For a hypovolemic client, it should be increased or normal. Edema, absent in a hypovolemic client, present in a hypovolemic client, especially because of the secondary causes of hypovolemia, heart failure, and liver cirrhosis, which are very common conditions. Urine output would be decreased if in a hypovolemic client, unless there is osmotic diuresis over there, but typically urine output is decreased. It is variable in a hypovolemic client, again, because of the complex functioning of the kidneys. It really depends on many other factors, including the osmotic potential of blood, the number of different hormones that are involved, the concentration of the hormones, ADH, aldosterone, etc. But what is invariable and does not change, irrespective of whether it's hypo or hypovolemic, it's body weight. That does not lie. So in a hypovolemic client, body weight is going to be decreased because you've lost fluid, you've lost water. If you've lost 1 liter of water, you've lost 1 kilogram of weight. That does not change. That cannot be altered. So body weight is the most sensitive measure of ECF volume, of total volume in the body, total amount of water in the body. In a hypovolemic client, body weight would be increased. So if you're going to retain 1 extra liter of water, well, your body weight is also going to go up by 1 kilogram. In the case of hematocrit, for a hypovolemic client, hematocrit is going to be increased because the amount of relative fraction of the plasma has decreased. Consequently, the hematocrit would have increased automatically, right? So if plasma is decreased, the hematocrit will increase automatically. In a hypovolemic client, the hematocrit is going to be decreased. So these two are fairly accurate measures of whether the client is hypo or hypovolemic. I'm not going to discuss urine sodium. Now let's talk about sodium concentration. Sodium concentration is different from the total amount of sodium in the body. So hypo and hyponatremia are disorders of water balance. If a client has hyponatremia, it doesn't mean that they have a lack of sodium in the body. What it means is that the relative proportion of sodium to water has decreased. Compared to water, there is a lack of sodium. Similarly, in a hyponatremia client, it doesn't mean that they have automatically an excess of sodium in the body. What it means is that relative to water, there is more sodium in the body compared to water. So it's really, hypo and hyponatremia are really disorders of water balance. Hyponatremia usually suggests that there is too much water in the ECF relative to the sodium content. Notice that it doesn't say that the sodium content has decreased. The sodium content might be the same, but if there is, relatively speaking, more water, then you will have hyponatremia. Think about a glass of plain water without any sugar, without anything else. Now you added sugar to it, right? It's become sweet water. You can measure the glucose concentration. If you have whatever the concentration is, if you add in more water, well, then the glucose concentration has decreased. The sugar concentration has decreased. Have you removed the sugar? No. You've added more water, and that's why the total concentration of sugar has decreased. The water tastes less sweet. That's what it means here. Hyponatremia, it doesn't mean that there is a lack of sodium. It typically means, it could be that's the case, but that's a rare situation. The more typical situation is that there is too much water relative to sodium. You've diluted down everything, including the sodium. Similarly, for hyponatremia, it suggests that there is too little water relative to the sodium. You removed more water relative to sodium, and consequently, the sodium has become more concentrated, resulting in hyponatremia. Hypo and hyponatremia are related in terms of their effects on the cells. So when you have hyponatremia, you have a decrease in ECF osmolarity over there. Consequently, what that does is that now you've altered the water balance, you've altered the osmolarity, and now you're going to have shifts of water. Specifically, water will move out of the cells if there is an increase in ECF osmolarity. That's what occurs in hyponatremia. And similarly, water will move into the cells if there is a decrease in ECF osmolarity. And remember, the main ECF cation is sodium. So when there is hyponatremia resulting in decreased ECF osmolarity, water will move into the cells will swell. Similarly, if you have an increase in ECF osmolarity, typically because of hyponatremia, water will move out of the cells will shrink. What that means is that the clinical manifestations of hypo and hyponatremia are all related to whether the cells have shrunk or swelled, especially brain cells. In the rest of the body, honestly, it doesn't really matter much if the cells shrink or swell, relatively speaking, but in the brain, in the cranium, which is a closed compartment, if the brain cells swell or shrink, you're going to get neurological deficits. So the clinical manifestations of hypo and hyponatremia are all neurological in nature. Specifically, hyponatremia is when serum sodium concentration is less than 135 millimoles per liter. The normal range of sodium concentration is 135 to 145 millimoles per liter. How can that occur? Well, dilutional hyponatremia is the most common. You've added more water relative to sodium. Relatively speaking, there's more water compared to sodium. So how do you get more water relative to sodium? That's the etiology. So what can cause hyponatremia? Very common conditions such as congestive heart failure, just heart failure, liver cirrhosis, nephrotic syndrome, pregnancy. Very common conditions. Pregnancy is not a condition so in terms of a disease, but nevertheless, those heart failure, liver cirrhosis, nephrotic syndromes can all lead to an increase in water relative to sodium, resulting in hyponatremia. The clinical manifestations of hyponatremia all depend upon the degree and, more importantly, upon the velocity of progression. So how quickly the hyponatremia develops. If it develops relatively slowly, there might not be any clinical manifestations. If it occurs very rapidly, if the sodium concentration drops very rapidly, then typically they are clinical manifestations. Why? Because hyponatremia, as we just explained, results in the swelling of the cells, especially brain cells. So the neurological symptoms are all related to the swelling of the brain cells that occur in hyponatremia. In other words, cerebral edema develops. So what are the clinical or neurological manifestations? Headache, nausea, malaise, weakness, a decrease in level of consciousness, personality changes, changes in various reflexes, and the like. Ultimately, as the brain swell even more, then you can have very serious complications, including the development of seizures, brain herniations, coma, and ultimately death. All this is because of the increase in the swelling of the cells due to cerebral edema that can lead to brain herniation and death. Hypernatremia, on the other hand, is defined as when serum sodium concentration is greater than 145 millimoles per liter. That is usually due to net water loss or insufficient intake. It turns out that hypernatremia is far less common than hyponatremia because when you think about it, as long as the thirst reflex is present, if you've lost water, the thirst reflex will kick into gear and then we will replenish the water. So as long as we can drink, hypernatremia shouldn't really develop, right? In addition, the role of ADH. So when there is an increase in plasma osmolarity, ADH is released, increased amounts of ADH is released, resulting in increased water reabsorption in the collecting tubules in the nephron, and that should protect against hypernatremia. And that's why hypernatremia is far less common compared to hyponatremia. So what are the etiologies of hypernatremia? Dehydration, again, that should be compensated by increased thirst reflex. The problems occur when the thirst reflex is affected, or you simply cannot replenish all that water that has been lost. So dehydration, for example, from sweating, severe diarrhea, burns, GI fluid losses, we already spoke about diarrhea or vomiting, as well as more rare example would be diabetes insipidus as well. So all that can lead to severe dehydration, leading to hypernatremia. Remember that hypernatremia results in shrunken cells. So water shifts out of the cells following the osmotic gradient into the interstitial spaces in plasma, resulting in shriveling of the cells, especially the brain cells. So what are the clinical manifestations of hypernatremia? Well, thirst and all the other manifestations of hypovolemia that we discussed in that chart previously. But because of the shrinking of the brain cells, you can have an altered neurological functioning, resulting in altered mental status, weakness, neuromuscular excitability, and various focal neurological deficits, mainly related to the functioning of the cranial nerves. The complications are similar to that of hyponatremia. It could be seizures, comas, and even death. One of the clues as to the specific etiology of hypernatremia might be if there is polyuria. That might be a clue that diabetes insipidus is the underlying cause of hypernatremia. Here's it in flowchart form. So hypernatremia could occur, the etiology could be because of a reduced intake. For example, in the elderly, hypernatremia is far more common because of swallowing difficulties, dementia, being bedbound, stroke, all that would reduce your intake, right? The thirst reflex might be affected, and even if that is present, it would be difficult replenishing the fluid losses. So reduced intake, especially among the elderly, in infants, obviously, they need to be given those fluids, typically by breastfeeding or formula feeding. A client that is post-surgical or in a coma, again, also has to be given fluid boluses, otherwise you're going to have reduced intake, and that can lead to hypernatremia. The other etiology would be increased losses that we've spoken about, GI losses, insensible losses from excessive sweating because of exercise, or even seizures, fever as well, and then renal losses, typically due to diabetes insipidus. Let's move on to the other electrolyte imbalances. So remember that sodium imbalances is all related to water imbalances. So hyper and hypovolemia is about total sodium content. Hyper and hyponatremia is about water balance, right? Let's discuss hyperkalemia now, or sodium balance. Hyperkalemia is defined when serum potassium concentration is greater than 5.0 millimoles per liter. What are the etiologies? Metabolic acidosis. How does metabolic acidosis lead to hyperkalemia? Well, that has to do in terms of how the body adjusts for the total number of protons, the acid, and potassium. So the body, in the case of metabolic acidosis, the body tries to compensate for all the acid, excess acid in blood. The cells will take in the acid, but because you have to balance charges, they will push out a potassium. So this is the acid, the proton potassium countertransporter. So the cells will take in the acid, H+, and push out a potassium, resulting in hyperkalemia. Aldosterone, if you remember from your A&P, is involved in potassium excretion in the distal convoluted tubule. So if you have a deficiency of aldosterone, you're not going to be able to excrete out the potassium. And remember, we mainly excrete out most of the potassium that we ingest, most of our potassium intake is excreted out because most of the potassium is locked up inside the cell, so we have very few losses of that. So aldosterone is absolutely essential in terms of excreting the potassium. Aldosterone deficiency, like in Addison's disease, can lead to hyperkalemia. If you have tissue damage, internal trauma, or necrosis, you can can result in hyperkalemia. Why? Because where's all the potassium locked up? Inside the cell. So if you have necrosis or trauma, the cells literally split apart and all the potassium is spilt out. That can result in hyperkalemia. The kidneys are essential in terms of regulating the potassium concentration. The kidneys will excrete out most of the potassium that is obtained in the diet, for example, so renal failure can lead to hyperkalemia. Similarly, in the case of excessive use of potassium-sparing diuretics, that can lead to hyperkalemia. And lastly, insulin deficiency can also lead to hyperkalemia because in the case of insulin, it activates the sodium-potassium ATP pump, and if there is a lack of insulin, the sodium-potassium ATP pump doesn't work as efficiently, and so less potassium is pulled into the cell. Ultimately, more potassium is left outside, leading to hyperkalemia. What are the clinical manifestations of hyperkalemia? Well, it's all related to cardiac functioning, specifically the intrinsic conduction system of the heart. Hyperkalemia leads to various arrhythmias, potentially lethal arrhythmias such as ventricular fibrillation and ultimately asystole. What are the ECG changes that occur in hyperkalemia? The main one are the peaked T waves. So if the P waves look very tall and peaked, that could be an indication of hyperkalemia. Bradycardia is also another common clinical manifestation. As the heart rate slows down, the cells become hyperpolarized, and it becomes more and more difficult to activate them, resulting in bradycardia. Weakness, nausea, and ascending paralysis and paresthesia are all about the altered resting membrane potential of the cells in the brain, as well as in the muscles. But that usually occurs only in severe cases. So what are the causes of hyperkalemia? We've already spoken about them. One of them that we didn't discuss is sample hemolysis. So this is called factitious, so it's not real hyperkalemia. So if the blood sample is drawn and it's not properly, either there's something wrong with the tube or it's not drawn properly, well then the red blood cells will lyse and hemolyze, and resulting in the spilling of all the potassium, and that would be measured as hyperkalemia, but it's not really hyperkalemia. It's just because of sample hemolysis of that. The main causes are, as we discussed already, rhabdomyolysis, for example. We didn't really discuss it, but that's an example of cell trauma. If the muscle cells start deteriorating for any reason, all that potassium gets spilled out. Similarly, in tumor lysis syndrome, where we spoke about insulin deficiency and metabolic acidosis, various drugs can also cause these transcellular shifts of potassium from inside the cell to outside the cell, such as the beta blocker, and we already spoke about insulin deficiency as well. And lastly, decreased renal functioning as well, along with NSAID use. That should probably be under here, but in the case of NSAID, it's because of its effect in decreasing renal functioning. Hypokalemia, on the other hand, is defined as serum potassium concentration of less than 3.5 millimoles per liter. Etiology is poor dietary intake. For example, individuals living in severe poverty, individuals who are unhoused, they're not going to be having a diet rich in fruits and vegetables, which is mainly how we get our potassium. That can lead to hypokalemia over long periods of time. Metabolic or respiratory alkalosis, that's similar to the opposite of what we discussed for hyperkalemia. Metabolic acidosis can lead to hyperkalemia. Similarly, metabolic alkalosis can lead to hypokalemia. As the cells try to compensate for metabolic alkalosis or respiratory alkalosis, they they push out a proton, and similarly they have to take in a potassium, and that can lead to hypokalemia. Vomiting, you lose all the potassium-rich fluid. Actually, vomiting and diarrhea lead to metabolic alkalosis, and that in turn lead to hypokalemia, as we just explained. Hyperaldosteronism, aldosterone promotes potassium excretion, so too much aldosterone results in too much excretion of potassium, leading to hypokalemia. Similarly, insulin excess leads to excessive activation of the sodium-potassium ATP pump. Too much potassium is brought into the cell, resulting in hypokalemia. And potassium-wasting diuretics. Most of the diuretics are potassium-wasting, like the loop diuretics, and that can lead to, like furosemide, and that can lead to hypokalemia. The clinical manifestations are similar to those of hypokalemia. It's all about various arrhythmias. But the ECG changes are different. In the case of hypokalemia, it leads to peaked tall T waves. Here, it leads to flattening of the T waves, as well as ST depression and the so-called U waves. Other clinical manifestations are less specific: fatigue, weakness, and paresthesias and paralysis, again due to alterations in the resting membrane potential. Let's move on to discuss the disorders of calcium balance, starting with hypocalcemia. Hypocalcemia is defined as serum calcium concentration of greater than 2.5 millimoles per liter. Remember, that's total calcium concentration, not ionized calcium concentration. The etiology is hyperparathyroidism. If you remember from your A&P, the PTH hormone is the main hormone involved in calcium homeostasis. Increased amounts of PTH will lead to increased bone resorption, leading to hypocalcemia. Neoplasms, various neoplasms can also cause hypocalcemia, mainly due to tumor lysis syndrome. In terms of the clinical manifestations, there's a phrase that helps us remember the clinical manifestations of hypocalcemia: bones, stones, groans, and psychiatric overtones. So why bones? As there's increased bone resorption, that results in deep bone pain because it affects the bone marrow. The bone becomes more and more fragile, resulting in an increased risk of fractures as well. In hypercalcemia, there's an increased risk of developing kidney stones, nephrolithiasis, and that's the stones part of it. And we examined nephrolithiasis in part 1 of Unit 6, so I'm not going to go over it again. Groans is much harder to explain, but calcium is required for the functioning of various neurons. We saw that at the synaptic transmission when you discussed it in A&P. You require calcium intake in order to release the various neurotransmitters. It is required for proper muscle contraction as well. It activates the sarcomere, etc. Not going to go through all that revision of A&P, but the bottom line is proper calcium concentration is required for proper muscle functioning as well as proper nerve functioning. So how do we explain all these GI symptoms? It's rather hard, but let's just say that abdominal cavity has lots of organs which contains muscles and neural connections, and ultimately this is how we explain the groans part of it. So there's nausea and vomiting, constipation as the mobility or the motility in the GI tract decreases, weakness. And lastly, we said that calcium affects neurological functioning, the functioning of the nerves as well, so there are various mental status changes as well. So the groans and psychiatric overtones are rather, shall we say, non-specific, but the bones and the stones we can easily explain by the increase in the calcium concentration. And that's because where's all the calcium stored? In the bones. Hypocalcemia is when serum calcium concentration is less than 2.1 millimoles per liter. The etiology, as you can anticipate, is hypoparathyroidism. Hyperphosphatemia also results in hypocalcemia because they kind of work in opposite directions. So if there's increase in phosphate, more calcium is sort of required in order to absorb the phosphate, and that results in hypocalcemia as well because the calcium is kind of bound to the phosphate. In the case of chronic renal failure, that can lead to hypocalcemia because in the kidneys is where you reabsorb. Remember, everything is filtered at the glomerulus, and you require the proper functioning of the nephron in order to reabsorb really everything back, including calcium. So chronic renal failure can lead to hypocalcemia. Vitamin D deficiency can also lead to hypocalcemia because vitamin D is required in order to absorb calcium in the GI tract. And lastly, loop diuretics also lead to increased calcium losses. So all those are the etiologies of hypocalcemia. Clinical manifestations also rather non-specific except for the last two. Abdominal pain, that's the groan part that was also present in hypocalcemia. Dyspnea, functioning of the lungs, how to explain that directly. Tetany, functioning of the muscle, that we can explain because calcium is essential in terms of the contraction of the sarcomeres. And then these last two, Shovstek sign, which is muscle spasm, facial muscle spasms when you tap the facial nerve, and Trousseau sign when you have carpopedal or spasms in your wrist when you inflate the blood pressure cuff over there. Again, all that has to do with neuromuscular functioning. We're going to switch gears now. So we've done the volume imbalances, we've done the electrolyte imbalances, and now we're going to do the acid-base imbalances. But first, just a little bit of revision on acid-base homeostasis. Remember, for AMP, there are two types of acids: CO2, which is the volatile acid; carbon dioxide is an acid, but fortunately we can excrete it out. And then we have all the metabolic acids, right? The lactic acid, hydrochloric acid, sulfuric acid, phosphoric acid, etc., that are produced from normal metabolism. So two types of acids in the body. There are also two types of buffers. The main ECF buffer is bicarbonate, and the main intracellular buffer are all the various proteins inside the cells. Please remember, you should really measure these and memorize these arterial blood gas values. So what is the normal range of pH in arterial blood? 7.35 to 7.45. It's going to be different in venous blood. It's going to be a little bit higher because of the increased CO2 concentration in venous blood. PCO2 36 to 44, and bicarbonate 22 to 26 millimoles per liter. Why do I have that single numbers over there? So for pH 7.4, for PCO2 40, and bicarbonate 24, because ultimately we'll see we have to solve these acid-base imbalance problems, right? So there's actual problem solving activities that need to occur over here. For that, there's going to be a separate video. So you're going to be given these three values over here: pH, PCO2, and bicarbonate, the ABG values, and then you have to determine what type of acid-base imbalance is present. So that'll be problem solving, and we work not off ranges. In that case, we work off single values. More to come. So respiratory acidosis is the buildup of CO2 in the body. So yes, there's a normal amount of CO2 that is in blood, in arterial blood. That's 36 to 44 millimeters of mercury. In the case of respiratory acidosis, we have a buildup of CO2. So when you have more CO2 than normal. So for respiratory acidosis, if the pH is less than 7.4 and PCO2 is greater than 40, not greater than 44, so we don't work off the ranges. So we're going to work off greater than 40, then it is respiratory acidosis. So if you see a pH of less than 7.4 and a PCO2 greater than 40, you know what the primary acid-base imbalance is. It's respiratory acidosis. Similarly, for respiratory alkalosis, it's the relative lack of CO2. So pH has to be greater than 7.4. That's a given, right? So acidosis is pH less than 7.4. Alkalosis is pH greater than 7.4. So for respiratory alkalosis, firstly, pH has to be greater than 7.4, so it's alkalosis. And then if PCO2 is less than 40, you're identified the acid-base imbalance, it's respiratory alkalosis. Similarly, metabolic acidosis is the buildup of metabolic acids. So in the case of respiratory acidosis, we can directly measure CO2, right? So if CO2 is above 40 and pH less than 7.4, it's respiratory acidosis. For metabolic acidosis, you'll say, okay, pH has to be less than 7.4. Indeed, that's true. And then let's just measure all the metabolic acids: lactic acid, oxalic acid, sulfuric acid, phosphoric acid, hydrochloric acid. Sure, you could do that, but that would take several weeks, right? And we don't have several weeks. These are specialized lab tests. So we have to measure it indirectly. And how we measure it indirectly is by measuring bicarbonate. Why? Because bicarbonate buffers all these metabolic acids. So the concentration of bicarbonate is really inversely related to the concentration of the metabolic acids. As the metabolic acids build up, more and more is buffered by the bicarbonate, and consequently bicarbonate concentration decreases. So to measure or to identify metabolic acidosis, firstly we measure pH. That's easy. pH has to be less than 7.4, and then we measure bicarbonate. Remember, we can directly measure all the metabolic acids, so we indirectly measure it by measuring bicarbonate instead. So when pH is less than 7.4 and bicarbonate is less than 24, why would bicarbonate decrease from its normal range? It decreased because there's too much metabolic acid. It's busy buffering out all the other metabolic acids. So when pH is less than 7.4 and bicarbonate is less than 24, it is metabolic acidosis. Similarly, if pH is greater than 7.4 and bicarbonate has increased, it's more than 24 millimoles per liter, then it's metabolic alkalosis. Let's look at these acid-base imbalances in tabular form. For respiratory acidosis, the pH has to be less than 7.4, and the cause is an increase in the PCO2. It's hypoventilation. We'll talk about the etiologies shortly. For metabolic acidosis, the pH has to be less than 7.4, and the cause is a decrease in the serum bicarbonate concentration because it's buffering all the excess metabolic acids. For respiratory alkalosis, the pH has to be greater than 7.4, and the cause is a decrease in the PCO2 caused by hyperventilation. And similarly, for metabolic alkalosis, the pH has to be greater than 7.4, and the cause is an increase in the serum bicarbonate concentration because there's less metabolic acids to buffer. For all these acid-base imbalances, remember there are two systems, the lungs and the kidneys. The lungs are there to excrete the CO2, and the kidneys are to excrete the metabolic acids. So in the case of respiratory acidosis, the problem is hypoventilation, for example, because of COPD. Again, we'll talk about the etiology shortly. So the only thing that can compensate are the kidneys. And what the kidneys are going to do is to increase renal reabsorption of serum bicarbonate in order to buffer out more of the metabolic acids. Right? So you want to get rid of the metabolic acids, and the way that is done in the kidneys is to increase the reabsorption of bicarbonate. Similarly, for respiratory alkalosis, you have, relatively speaking, less CO2 because of hyperventilation. More CO2 has been excreted out. Consequently, the renal compensation is to increase the amount of metabolic acids, and you do that by decreasing the renal reabsorption of bicarbonate. For metabolic acidosis, the problem is that there are too many metabolic acids, and that is measured by the decrease in the serum bicarbonate concentration because you've buffered out as much of the metabolic acids as possible. And so the only thing that can compensate now is to get rid of some CO2, because CO2 is an acid as well. You already have too many of the other metabolic acids. You want to get rid of CO2, and so the lungs will compensate by hyperventilation in order to decrease the PCO2. Similarly, for metabolic alkalosis, you have, relatively speaking, too little metabolic acids. Consequently, serum bicarbonate concentration has increased, and therefore you want to retain more CO2. The lungs will compensate by hypoventilation in order to increase the PCO2. So the way that we remember all this is by using this mnemonic ROME, respiratory opposite metabolic equal. What we're doing over here is looking at the signs or the directions of change for pH and the primary cause over here. So respiratory opposite, pH decreases, and that's because CO2, PCO2 has increased. Similarly, for respiratory alkalosis, pH has increased because PCO2 has decreased. Respiratory opposite. For metabolic acidosis, the pH has decreased, and you can see that's because the serum bicarbonate has decreased. Metabolic equal, same direction, pH down, bicarbonate down. And for metabolic alkalosis, the pH has increased up, and that's because the serum bicarbonate has increased up, metabolic equal. Now, if you look at the compensation, you will see that the compensation is always in the same direction compared to the cause. So if CO2 goes up, the compensation is bicarbonate has to go up. If bicarbonate goes down, as in metabolic alkalosis, then the PCO2 has to go down. If PCO2 has gone down in respiratory alkalosis, then the compensation is bicarbonate has to go down. Similarly, for metabolic alkalosis, bicarbonate has gone up, hence PCO2 has to go up. The compensation is always in the same direction as the change in the original cause. And that's because of the Henderson-Hasselbalch equation, whereby pH equals to 6.1 plus the concentration of bicarbonate divided by 0.03 times PCO2. It's the ratio of bicarbonate over CO2. It has to be a 20-to-1 ratio. So if, like in metabolic acidosis, if the bicarbonate has gone down, the numerator has gone down, that means it's a less than 20-to-1 ratio. The only way you can get back to a 20-to-1 ratio is for the denominator to also decrease. The PCO2 has to also decrease. And you can work the relationship out for all these other acid-base imbalances. Essentially, it is all about maintaining the 20-to-1 ratio of bicarbonate to CO2. Here's another table that explains the same thing over here. So just very quickly, for metabolic acidosis, pH has gone down, and that's because acidity has gone up. The primary cause is a decrease in the serum bicarbonate. The compensation is a decrease in the PCO2. For metabolic alkalosis, pH has gone up because the acidity has gone down, the H+ has gone down. The primary cause is an increase in the serum bicarbonate because there's less metabolic acid. Compensation is to increase the CO2 via hypoventilation. For respiratory acidosis, too much CO2 is built up over here, hence acidity has gone up, pH has gone down. Respiratory opposite when you're comparing the pH and the CO2. Similarly, for respiratory alkalosis, the cause is hyperventilation, so PCO2 has gone down, acidity has gone down, pH has gone up. The relationship again for the ROME acronym is respiratory opposite, and that's because we're comparing the pH and the PCO2 over there. We'll talk about these causes in a second, but we'll do that separately on the remaining slides. So the main point of these acid-base imbalances, besides knowing the etiology, is to do some problem solving when given the ABGs, or arterial blood gas values. Remember, the ABGs tell you the pH, the PCO2, and the serum bicarbonate. The first thing that you look at is the pH. If the pH is less than 7.4, it's acidosis. If it's greater than 7.4, it's alkalosis. Then you look at either the serum bicarbonate or the PCO2. I like to look at the CO2 first. So if it's pH less than 7.4, we know it's acidosis. The only question is respiratory or metabolic. If it's PCO2 greater than 40, respiratory opposite, it's respiratory acidosis. CO2 is built up, and that's why the pH has gone down. What's the compensation for respiratory acidosis? Well, it can only be renal compensation, and you already have too much of CO2, so you want to get rid of more metabolic acid. The only way you can do that is by increasing the renal reabsorption of serum bicarbonate. The PL stands for plasma, and hence serum bicarbonate is going to increase above 24. Don't use milliequivalent, use millimoles per liter. So pH less than 7.4, acidosis, and now if you look at the serum bicarbonate and it's less than 24, that's the equal sign over here. They're both moving in the same direction. It has to be metabolic acidosis. The only compensation is the respiratory compensation. The lungs are going to try to excrete out more CO2, so you have hyperventilation in order to get rid of more CO2. PCO2 is going to decrease below 40 millimeters of mercury. If the pH is greater than 7.4, it's alkalosis, and if the PCO2 is less than 40, respiratory opposite, then it's respiratory alkalosis. The only compensation is for the kidneys to reabsorb less bicarbonate, and serum bicarbonate concentration should be less than 24 millimoles per liter. That will be the expected compensation. Similarly, if pH is greater than 7.4, alkalosis, and if serum bicarbonate is greater than 24 millimoles per liter, it's the same direction, hence it's metabolic alkalosis. The only thing is for the lungs to now try to compensate by increasing the retention of CO2, and that's going to be done via hypoventilation in order to increase PCO2 above 40 millimeters of mercury. So we're going to be solving these problems, but there's going to be a separate video that shows you how to go about solving these problems when given the ABGs, the pH, the PCO2, and the bicarbonate. So please have a look at that particular video under the other resources in Unit 6 on Blackboard. Here's a similar flow chart to the one that we just saw. I'm not going to go through that. You can work through it yourself as well to land up at the identification of the primary acid-base imbalance and then what is the expected compensation as well. And this particular diagram also shows you the etiologies, which we'll be doing next. So for respiratory acidosis, the etiology ultimately is hypoventilation. You're retaining too much CO2 because of these causes. This could be due to the depression of the respiratory center, resulting in a decreased respiratory rate. That could be due to various drugs, such as the narcotics, like fentanyl and the other opioids. Could be due to trauma to the brainstem. Could be due to a stroke. Neuromuscular disorders can also cause hypoventilation. That's not very common outside of very severe cases of botulism or in stages of ALS, amyotrophic lateral sclerosis, where the diaphragm and other respiratory muscles get paralyzed. The most common cause of hypoventilation, the obstructive lung disorders, such as COPD, cystic fibrosis. Asthma is interesting in that at the initial stages of acute exacerbation of asthma results not in respiratory acidosis but alkalosis because of hyperventilation. However, if that doesn't resolve itself, then the work of breathing becomes more and more difficult, and eventually the breathing rate slows down and it switches from hyperventilation to hypoventilation, thereby resulting in respiratory acidosis. That's an ominous sign. Other causes of respiratory acidosis, it could include pulmonary edema, pneumothorax, pneumonia, and ARDS, or acute respiratory distress syndrome. What are the clinical manifestations of respiratory acidosis? It's hypoventilation is the main clinical manifestation, resulting in the buildup of CO2, and respiratory acidosis. Dyspnea might occur as well. The remaining clinical manifestations are less specific. They include sleep disturbances and daytime somnolence, as well as progressive neurological deficits as the CO2 builds up in the brain. The acidity is going to affect neurological functioning. For respiratory alkalosis, it's all about hyperventilation. So what can cause hyperventilation? Severe anemia can cause it as you try to increase your breathing rate in order to compensate for the reduced oxygen carrying capacity of blood, heart failure, as well as various pulmonary diseases such as pneumonia, pulmonary embolism, and interstitial fibrosis. Various drugs such as acetylsalicylic acid or aspirin, catecholamines, progesterone as well can stimulate the respiratory centers. The opioids cause depression of the respiratory center. ASA and the catecholamines can stimulate the respiratory center, causing hyperventilation, thereby causing respiratory alkalosis. The gram-negative sepsis can also cause hyperventilation, as can anxiety and severe pain. Living on high altitudes, or even, if you're mountaineering up the Himalayas, that can cause hyperventilation because of the decreased oxygen content in air. What are the clinical manifestations of respiratory alkalosis? Hyperventilation is the main one, along with dyspnea and potentially chest pain, as well as paresthesia and peripheral numbness. This is hard to explain, but it might have something to do with the increasing dysfunctional capabilities of the nerves. So the nerves become more and more dysfunctional, especially the free nerve endings. That could potentially be due to vasoconstriction, but regardless, that is a feature in respiratory alkalosis. Tetany, as the neuromuscular functioning also becomes more and more dysfunctional. The hypocapnia in the brain, or the reduced PCO2 in the brain, ultimately can trigger cerebral vasoconstriction. All right, that's a phenomena, and that in turn can lead to progressive neuronal ischemia, thereby leading to various neurological deficits such as mental confusion, syncope, all the way to seizures, as well as coma and perhaps death as well. For metabolic acidosis, the etiology is lactic acidosis if you have to rely on anaerobic respiration, ketoacidosis for the type 1 diabetics who have a lack of insulin, ingestion of various toxins such as methanol, which is formed in moonshine, ethylene glycol, salicylates, advanced renal failure as the kidneys are no longer able to excrete out the metabolic acids, and diarrhea, which is due to the loss of all the bicarbonate from the bicarbonate-rich fluids in the lower GI tract. The clinical manifestations are, in terms of, in this case, the compensation in the lungs would be hyperventilation in order to get rid of more CO2. So it's called Kussmaul's breathing. Especially individuals with diabetic ketoacidosis, they will display this Kussmaul's breathing, which is deep, rapid respirations. In addition, metabolic acidosis can result in decreased cardiac output and tissue perfusion, and that is believed to be due to the reduced responsiveness of the catecholamines, the epinephrine and norepinephrine, in the sympathetic nervous system, the neurotransmitters in the sympathetic nervous system. Lastly, for metabolic alkalosis, that could be due to vomiting or nasogastric tube suctioning as you remove all the acid-rich secretions in the stomach, or it could be due to renal losses of acid, or various diuretics, especially the loop diuretics such as furosemide. The clinical manifestations are not very specific. It just has to do with the compensation, the respiratory compensation, which would be to try to retain as much CO2 as possible. That would result in hypoventilation. That brings us to the end of part 2 of Unit 6. In summary, please remember to go over the etiology, the modifiable risk factors, pathogenesis only very briefly, but most importantly, focus upon the clinical manifestations of the various diseases, disorders, and conditions that we covered in this particular slideshow, as well as the learning outcomes of Unit 6 that are listed in the syllabus. Remember, you'll only be assessed on the learning outcomes that are listed in the syllabus. Please contact me via email or your instructor if you require any clarification about any of the content in this particular lesson or in any of the other lessons. That brings us to the end of this section, which is the halfway point of NURS 2020, whereby we've covered most of the pathophysiology. Not all of it, because we only had 6 weeks, but most of it. So please remember that the midterm will cover the learning outcomes from units 1 to 6. Always refer to the syllabus for the learning outcomes, as well as for the format and any further details that you might require for the midterm. I want to wish everyone the best of luck on the midterm. I know you're going to do really well. Everyone's going to do awesome on it. The second half of the course will switch gears completely and focus upon microbiology and various infectious diseases. Thanks, everyone. Have a wonderful day. And again, good luck on the midterm. See ya.